Welcome. My name is Beth Stronach, and I'll be hosting your webinar for today. This is our January webinar. I am mom to Sam, who is a child that has Noonan syndrome, and I advocate for him and others on behalf of RASopathies Network. Our mission is to advance research to improve the quality of life for RASopathies families and individuals by bringing together families, clinicians, and scientists. Our volunteer board is shown here. Lisa and Lee started this organization back in 2009. I am here with my son, Sam. This is Bruce Steckman and his son, Colin, and Kara Borian and her daughter. So I just wanted to mention, we do several campaigns as part of our advocacy. And we recently had a Giving Tuesday campaign where we raised almost $10,000 to do some of the things that we do, including hold our symposium and fund research projects. And I just wanted to show you that along with this timeline, you know, there's been a lot of progress over the last 30 years from the identification of the NF1 gene in 1990 and the identification of the PTPN11 gene in 2001. RASnet was founded in about this middle point, and every other year we're bringing together these stakeholders, scientists, families, clinicians, counselors, and we get to discuss all the incredibly amazing science and the advances that have been made and where we need to go in the future. So I think it's important for the community to stay involved, and hopefully we can reap the benefits of trying to accelerate the progress. We've just got word that our new awardee for the MDBR application is Dr. Joe Streisma, and he's going to be working on the central conducting lymphatic system. So this is our 9th funded project. And our 8th international symposium will be held in Denver this summer, July 21 through 23. And we have 3 excellent meeting chairs, Dr. Andelfinger, Dr. Bennett, and Dr. Pierpont. So stay tuned for more information about that. We would love to see you in person, but we will also have a virtual option. All right, so just to remind you that these are the RASopathies syndromes, and this is the pathway or the network inside our cells that sort of binds us all together. We're here because we have loved ones that have a RASopathy, or we are individuals that have them. And today we're going to host a speaker who will tell us about how this pathway is impacting these syndromes. And if you imagine having a little bit too much activity circulating through the cell, going through these arrows, the point of developing inhibitors is that you can slow down or put the brakes on the signaling or the activity through these signaling networks. And so we're going to focus today on the MEK inhibitors, which I've shown here as just one of many drugs that are in the pipeline to inhibit the RAS pathway and its downstream components. So we're really happy to have Andrea Cote and Tara McKeown here today to tell us a little bit about the MEK inhibitors and from their experience actually in the clinic with clinical trials. So I'd love to introduce Andrea Cote. She is also a parent and advocate for her child with Noonan syndrome, and then she will introduce our speaker. So I will stop screen sharing and you can take it away, Andrea.
I'm Andrea Cote, and I'm a parent to a 2-year-old boy, William, who has Noonan syndrome, SOS1 gene mutation. And prior to becoming a mom, I actually worked as a nurse in pediatric oncology for many years, and I had the privilege of working closely with Tara McKeown, who is our presenter today. Tara is a nurse practitioner at the Hospital for Sick Children in Toronto, Ontario, Canada. She's been working with MEK inhibitors and specifically trametinib in pediatric patients since their infancy in phase 1 clinical trials. And I was thinking about it, Tara, and I think it might be close to 10 years now that you've been working with trametinib, which is a long time. She has developed a unique expertise in side effect management with trametinib in pediatric patients, and she's a resource to medical professionals across the world in accessing and managing side effects for patients on trametinib and other MEK inhibitors. She's here to teach us a little bit about more what is a MEK inhibitor and some of the common side effects that we see in pediatric patients and how we manage those. If you have any questions, just feel free to drop them in the chat and we'll have time at the end to answer as many as possible. Thanks. I will let you take it away, Tara.
Perfect. Thank you. Thank you so much for including me. One of the favorite things about my job is being able to collaborate with families. And I know I don't directly work with this group of patients, but I think it's great that we can just come full circle and share expertise. And then also should also mention that this presentation is very similar to one that Andrea and I did together a number of years ago. So she had a big component in this as well. There we go. Okay. Okay. So as you guys said, the objectives, we're going to try to go through family education and engagement with MEK inhibitors, some review of side effect profiles of MEK inhibitors, briefly talk about management of them, but I'll just kind of say that they can be different, but just kind of general overview of what that looks like, and then overall length of therapy as well too. So just to say that this presentation is based off experience in working on clinical trials, compassionate access, off-label use. I'm not representing any pharmaceutical companies. And then the photos used for this presentation cannot be disseminated or copied for use outside of this presentation. So just like me doing a quick PubMed search, it's quite clear that the use of MEK inhibition is becoming more prevalent in the RASopathy population. And you guys are the experts in this population. I just needed to kind of dip my toes in just to kind of see what is out there right now. Okay, so this is, I want to say I just love your picture of your RASopathy cell and how you all come together. I think that's such a beautiful way of just scientifically and also collaborating together. It was really neat. So this isn't new, I guess, to you guys. So this is just briefly showing the RAS-MAP kinase pathway. So you can see the many alterations that exist within the pathway from this FGFR1. There's also FGFR2. There's an N-tract alteration. PTBN11 is one that you guys are quite familiar with, just the RAS gene in general, specifically with NF1. And then going downstream, we have BRAF, MEK1, and MEK2. And as you can kind of see in this slide over here, the thought is that a MEK inhibitor should directly target kind of MEK1 and MEK2. And I don't think people appreciated when we started using these, even though these are all part of a RAS MAP kinase pathway, that there would be effect upstream on these patients' population, because we have a couple of patients that happen to have FGFR alterations that we didn't actually think they would benefit from MEK alteration or MEK inhibitors. So just moving on to here. So similar type picture here. This is just kind of summarizing it a little bit more. So yes, like we said, we thought that MEK inhibitors would kind of have a direct impact on the MEK1, MEK2, but there is this upstream effect on the pathways above it that eventually heads back downstream to the cells and that affect cell growth or cell apoptosis when there is something wrong in those genes. So more broadly, I'm going to speak a little bit, you'll hear a little bit about BRAF inhibitors, since these drugs originated originally from the melanoma population. So metastatic melanoma used to have a very poor survival. And when they did more research, they found a good majority of the patients with melanoma had this mutation called BRAF V600E. It is now, for patients with metastatic melanoma, it's upfront therapy for these patients patients to get BRAF inhibitors and MEK inhibitors that are used concurrently together. So you can see that the dabrafenib BRAF inhibitor targets the BRAF pathway, and then the trametinib directly targets a MEK pathway, and then downstream to the cell. So that got approved. The drug company made these drugs. So then, since we knew that these drugs were out on the market, scientists were trying to figure out what other alterations could we use these drugs for, because as you know, drug companies are not going to make drugs for smaller diseases. So from there, from my world, we found that in the pediatric brain tumor population, there was a lot of alterations, whether it be in the BRAF V600E, but also in the BRAF MEK BRAF fusion part. So they started clinical trials where we started using these medications, and we still have some time to come. We're not as far as melanoma, but we've made some really good strides. So that's just a little bit of history so you can understand where they've come from. And then as time has gone on, we have realized the impact that they can have on the whole RAS MAP kinase pathway. So from there, I'm just just stepping a little bit away from the science, important, but I think let's talk about the nitty or gritty stuff that's important. So when we're starting a family on MEK inhibition, we do a lot of teaching and engagement with the families. We go over how to administer these medications. We go over side effects, prevention of toxicity, and then the long-term treatment that might be happening. So some of the things that we talk about with medication and compliance and administration is just, especially with kids, making sure if there's other children in the house that the medication's locked up from a safety perspective. We try to encourage them to have diaries to ensure that this medication is being taken regularly. There is some MPO, so fasting guidelines that need to be monitored in order to give this medication, and then review this at every visit that they come to. And then also just that anticipatory guidance of there's going to be side effects with this medication. So we speak through what these side effects are going to look like, because most families, and myself included, it's better to know what to anticipate than to be surprised with it. I always chat to them about, let's have a plan. If we don't have to use it, great. But if we do, we have an idea of what to do. So we go through all of the potential nitty gritty. Every patient gets a rash, is what I say. To what capacity this rash looks like can be very variable, but everybody gets some type of rash. What we haven't been good at predicting is when are they going to get it? What type of rash? Why are some worse than others? So I'll go into that a little bit more. And there is a lot of other side effects that you'll likely or have already read about, and I'll try to touch a little bit into those as well too. But some of our prevention strategies, because the vast majority, there could be other side effects, but the skin one is the biggest one. So stuff that we talk to families about doing ahead of time is doing daily short baths or showers with warm, not hot water, avoiding any irritants such as bubble baths or soaps or bath bombs. And then when you're getting out of the water, just patting yourself dry and directly applying moisturizer. And there's always the question of what type of moisturizer. So from our collaboration with their dermatologists, so stuff that comes in a tub as opposed to a pump is more penetrant. So we provide some recommendations based on that. The importance of daily sunscreen. I'm in Toronto right now and it's chilly outside. So even in the winter, the importance of putting sunscreen on their face is important. Keeping nails short, cutting straight across. I'll show you some pictures of how we prepare families to do that. We try to have a baseline dermatological assessment. So we just know, is this a kid who already has sensitive skin, or is there other things that we need to be aware of? We seem to see the effect that climate plays on the rashes. So being in Ontario, the winters are harder to manage the rashes, the dryness, the cold weather, that seems to play an effect at making it worse. Some families highly recommend the use of humidifiers in room and swear by that. And then some other things that we're starting to do is particularly with the post-pubertal population is pre-medicating with doxycycline, which is a anti-acne medication. So this is something we're trying to collaborate with our dermatologist to do. And then also, depending on the reason why we're treating, this is at least a 1.5 year treatment, and sometimes can be much longer. So it's the mentality of this is chronic disease treatment, and just acknowledging things that, and then you guys know this well, that you guys are an expert in your disease and you will become an expert in managing these side effects. And I learn along with my families just as much as they do. They'll teach me tricks that I share with other families as well too. So what's worked really well for our center is just being able to collaborate with other departments. There is a bunch of different tests that need to be done to ensure safety of this medication. So we've developed some good collaborative relationships with dermatology, cardiology, ophthalmology, diagnostic imaging, because we need to make sure that all of these things are in place in order to appropriately evaluate the child and the side effect profile. This is our 2 dermatologists that we work with closely who are really engaged. So the importance of finding a local dermatologist, someone who's engaged in targeted therapy, is really important. It's tricky, and this is the biggest struggle that smaller centers seem to have. We also, I share my email with a lot of the families because it's easier to be preventative. And as soon as a rash is starting to develop, I encourage them to kind of email me pictures of what it's looking like, so I could send a prescription closer to them, so we could kind of try to tackle the rash before it gets worse, before they come to see us. We've also developed this joint clinic with dermatology and oncology, which just kind of helps us collaborate a little bit better and provides us with better access to our dermatologist. So yes, and just kind of how we're saying, how the common ground that we found specifically with oncology from my home into dermatology, and how we're just collaborating together in order to be able to maintain the use of MEK inhibitors while reducing the skin toxicity. Okay, so here are some of the stuff you guys are probably interested in hearing. So here are some pictures and side effects, some more dramatic than others, of MEK inhibitor induced rashes. So just, you'll see this word grading that we talk about. This is kind of a research word, because whenever these kids are on clinical trials, we need to grade all the different side effects that they're having. So it just kind of, this allows you to understand what this means for a skin side effect grading. So this one is a grade 1 eczema. It's some of these pictures are a little bit hard to see, but you can kind of see within the plantar surfaces, like between the, like at the elbow fold, and then their neck, there's a redness in there. And this is a little baby that has more eczema that's present all over the body. So stuff that we would do to kind of prevent or reduce that: gentle skincare, moisturizing. We use a lot of topical steroids, because the thought is that these rashes are driven by inflammation. So if we can reduce the inflammation by using topical steroids, that will reduce the rashes. And then depending on the severity or how they respond to topical steroids, we have different types of potencies that we use. So this is called I was having trouble with this word, erythematous eruption. So these look, they're flat rashes or circular, and they can be very sparse, or many of them throughout. And we treat them very similar. Here's another more extensive picture of that. And then also treat them very similar to the eczema. So you're going to see a lot of moisture, the importance of moisturizing, and then the use of various steroid cream as well too. And also minimizing activities might further dry out the skin as well. And sometimes what's difficult to understand is that when you start to see the rash flaring, we talk about the rash at the worst, you'll see a lot of redness, maybe some itchiness present as well too. But then as the rash is getting better, it might not still look like the quote unquote normal skin that we would have seen, but you might see just a flat part on the skin, but the skin is like hypopigmented, so it's a different color, and that's just all the healing process of the skin rash that happened. This is the big one with traumatic, the acneiform eruption. So it seems to be in children who has not gone through puberty, the acneiform eruption seems to happen away from face and back. So it can be like, for instance, this child was just on this leg, so it was very significant on this leg here. For instance, but with adolescent patients, we see quite significant where all their hormone glands are on their face and on their back. So typical acne spots, but generally can be more intense. So these are just some other pictures of, and they can be painful and swollen. So there's so the thought, and this is where with these patients in particular, so these are the patients that we're trying to get ahead of these rashes from erupting, so starting them on anti-acne medication beforehand in order to reduce the effect that it has once they start the trametinib or whatever MEK inhibitor they might be on. So management, like I said, can be quite varied. It can be a lotion that has antibiotics in it. We can sometimes use in combination with steroid cream, because once again, these are still driven by this inflammation. So reducing the inflammation helps reduce the acne. Every time I talk to families about these bleach baths, they think I am crazy in saying that, and it's not dumping your child in a bathtub of bleach, but it's more creating a consistency, probably very similar to a swimming pool. There's lots of good evidence for this in the eczema world, and the thought, and there's some clinical trials looking to see if this actually does. The thought is that this might reduce the instance of these acneiform eruptions. And then other stuff, sometimes we need to do a course of oral antibiotics like I talked about, and it's varied depending on the age of the child. This is our recipe that we provide families with for these bleach baths, but once again, it's just about this similar consistency of being in a chlorinated swimming pool. And sometimes some families just elect to go to a chlorinated swimming pool as a prophylactic management as well too. Paronychia, or ingrown toenails, would be something that we see often. Never in my life did I think I would look at so many toes, but this is something, and especially with kids in their fingers, because kids like to pick at things because it seems interesting or it spends time. So there's little pieces of skin, and then little bits of inflammation can happen, and it can lead to just some redness or inflammation or infection as well too. So these are just some different pictures of what things can look like, or more severe ones as well too. So as you could appreciate, this can be quite sore and quite painful for these guys. So how can we prevent this? So we talk about, if you can see my cursor here, like correct toenail trimming. So instead of making this curved piece, cutting straight across. And the idea behind that is that so the skin doesn't get stuck in this, or so the nail doesn't get stuck in the skin right here. And then the other thing that we recommend if they're starting to have some swelling around their nail beds is to soak twice a day with whether it be Epsom salts, or we also say diluted vinegar soaks. And then there's some application of various steroid creams. If we're worried that something's getting infected, then we try to see if we can manage it without oral antibiotics. But if we do, we swab it to make sure we're giving the right antibiotic. We've also been using, that I haven't included in here, some other medication off-label to reduce granulation tissue that's been happening as well too. And at last resort, sometimes we need just a toenail excision from our surgery team. This other tension taping is something else that a lot of families do, and the idea is after you finish soaking the foot is grabbing a sticky piece of tape, like I normally recommend duct tape, to try to gently pull the skin away from the nail in hopes of just allowing that skin to move back. So yeah, that's a lot of skin stuff. And I think I'll just maybe stop there to say that this is, I always spend so much time telling families that this is a lot. It's a lot of time having to moisturize your child every day, to do all of these nitty gritty lined up creams that you need to do. So these families do a fantastic job, but it's hard. I get it. I have a hard time putting sunscreen on my kids regularly. So this is a lot. Some other skin stuff is mucositis, so mouth sores, blepharitis, which is kind of like, we can see styes would be something else. So treat it very similar to that, but like kind of lid scrubs. This one family who used to get it all the time swore by this humidifier that was blowing right on the child's eye. And then there's sometimes, if needed, that we use a prescription drop or steroid drop if necessary. Fissuring, a fancy word for just kind of opening of the skin. So sometimes we'll be creative and try to soak the toe and moisturize in some type of moisturizing cream, and then wrap it up in saran wrap to like penetrate all of the moisturization to go there. We sometimes encourage liquid band-aids to kind of get that part of the skin back together. And obviously managing or looking for infection. Hair loss is something that seems to happen, and I don't think we really appreciate to the extent that that is. It's not a complete hair loss, but it's certainly something that we see over time, and it's normally something that happens 3 to 4 months after being on medication. It normally stops at a period, I want to say around that 7-month period, and then there's this new hair regrowth that happens, more coarse often. And then yes, there also can be the change in color, where these kids who might have dark brown hair, they have this blonde, beautiful blonde hair after it. So just different stuff that can have an impact on self-esteem, obviously. So, but things to be aware of. Other side effects can be significant, or not significant, but not as common. Weight gain is something that we've seen I work with kids who have diabetes insipidus because of their brain tumor. So their GI can change. Edema, cardiac toxicity, I'll talk a little bit about. So this is just a growth curve of someone presented to us here, and then was started on MEK inhibitor therapy, and then gained a fairly significant amount of weight, and then kind of went back and forth for a little bit, and this is when they came off MEK inhibitor therapy. GI stuff. So for kids who have diabetes insipidus, it seems we have seen decreased use or need for desmopressin, which is also interesting and something to be aware of. We've seen increased prevalence of this unilateral peripheral edema, which for the most part is typically asymptomatic and works well with whether it be compression stockings. But there has been some instances that are a bit more significant than others, so we monitor for that. These are all not as common as skin, I just want to reiterate again. Cardiac toxicity, so this was something that was really big in the adult literature, and we still understandably make sure that we monitor the heart. All of our side effects from a cardiac perspective has been asymptomatic, so the child has been fine. The things that we have that is documented in the literature is elevated QTC. So we just try to be mindful if there's other medication that could prolong that QTC. We have sometimes seen change in the ejection fraction. So we monitor their function via echocardiogram. And then we've also sometimes seen change in their valves when we're looking at their echocardiogram. Like I said, the pediatric literature nearly all is asymptomatic, but because these kids are young, we're obviously wanting to monitor their heart very carefully. Pyrexia or fevers are something we see not as commonly with trametinib, but it can happen. This is more common with dabrafenib. So length of therapy. This is, in my world, it's a little bit unknown as far as how long. The clinical trials have been variable. Some didn't, the early clinical trials didn't expect there to be such good findings, and then they are allowed to just continue on these medications. And now new clinical trials are starting at 18 months and then moving to stop at 24 months. But what we're seeing is that there's a group of patients that as soon as we stop the MEK inhibitors, they have this rebound growth, so grow back if they've had this change in size in their MRI. Or another group of patients have this slow growth over time because our patients get monitored with MRI brain scans over time. And then there's another group of patients who don't change. Once they stop, they're okay. So once again, giving that anticipatory guidance to families, we share with them that we're not sure if we're going to have to restart, but we know there's a group of patients who don't need to be restarted. So we're going to stop here. But if we do need to restart, then this is what it's going to look like. So it's a lot of chronic disease management. We have this pediatric oncology, neuro-oncology consortium group that we're working together to try to find ways to perhaps wean this trametinib over time. So slowly stop it as opposed to just stop it dramatically to see if that has any benefit on their tumor. So a lot of unknowns as far as when to stop. And then as I talked about before, in the empowerment of families, so it's a huge responsibility on you guys, and you guys are incredible advocates for your families, but continue to provide them with that positive feedback that, you know what, if we can't figure out this rash right now, we are gonna find another way to figure out this rash, and just lots of collaboration together. And some of the long-term families who have been on MEK inhibitors for 5 or 6 years are always so great at being able to share their advice of what works and knowing when there's going to be more challenging times. And then just the importance of having this education partnership with the dermatology team. So what's new, what's upcoming, what are we missing? So what currently I think needs to happen is different toxicity profiles in different MEK inhibitors. I work with a couple different ones and can definitely appreciate some have more side effects than others. And then also I work with a good proportion of children who have NF1. So those children seem to be a bit more sensitive than children who do not have NF1. So that needs to be looked at in a clearer lens. And then just as I mentioned, the response rate and who can we stop? Like who can we stop without having to jump back on it? And the question about potentially weaning, and maybe not weaning off, but weaning to a smaller dose that doesn't have as much side effects. And then we need to be better at being able to be predictive of what type of rashes are based on age, skin tone, temperature, and various things like that, just so we can better advise our families and better know of when these things are coming on, whether or not that will happen, but that would be something great to know. And something that I did not mention either is just the long-term side effects are unknown of these drugs. So is there impacts on fertility? Is there other impacts on this child's body that we're not aware of right now? We know of a lot of long-term side effects for regular chemotherapies that we give the patients population that I work with and guide them when they are coming off of them and going into adult world. But I share with our families regularly that these drugs are still new to these patients. We don't know what this could mean, and just so there is that understanding as well too. And then for our patient population, we're trying to decide, is MEK inhibitors, should they be combined with other types of therapies, such as different chemotherapies? And then also I'm gonna, the last point to ponder is having an official parent forum to inform other parents about their skin management techniques. Some families are so great at sharing me different tips and stuff, that whether something should be published with the parent perspective as well too. So some final take-home points. We're a little bit uncertain when to stop and if we can restart with that same effect when we do restart. The importance of side effect management, partnering with dermatology, ophthalmology, cardiology, and partnering all together with patient and family system. Long-term side effects are unknown, and then the quality of life needs to be studied in comparison to other traditional frontline therapy if that exists for your population. And then I didn't get into the specifics, but the goal with trying to reduce the rashes is trying to not have to stop the MEK inhibitors, because we have seen variable responses of having to start and stop or give smaller doses as well too. So we try our best to give the most recommended dose based on the patient's age and size. And then we still need evidence-based guidelines and education for monitoring or for managing toxicities for pediatric patients on targetable agents. And then I will just leave it at that and open up the discussion for questions.
Yeah, I hope that didn't scare any parent who's about to go on trametinib, because I think the pictures are often more severe, but some patients have much milder skin side effects as well. But yeah, if anyone has any questions, you can either raise your hand or feel free to write them in the chat.
I actually have a question. I can start people off.
Sure.
Maybe you can share what indications are families actually being or taking trametinib for. So aside from what you're doing in the clinical trials right now, I'm not sure we covered sort of why certain RASopathy patients might be offered this, because it's not officially approved, right? So we probably should talk about that.
Yeah, and I'm not sure if I'm, to be honest, the best person to ask that, because so I work with children with brain tumors, and so we have a handful of children that have NF1. So specifically for their brain tumor, so if there's progression in their brain tumor, decrease in their ability, often their brain tumors can impede their ability to see. So we sometimes, if their visual acuity is getting worse, we sometimes start another line of therapy because of that. We've also taken on a bunch of patients with NF1 who have these plexiforms, so these benign growths along the peripheral nerve sheets, even though they don't have brain tumors. But because we developed this expertise, we kind of took those kids on. And since they didn't have any known therapy, we were starting them based on a bunch of modalities. So specific to that was pain or dysmorphia or the size of it, unable to be surgerized or anything like that. So, but I haven't, as we were talking before, haven't been involved in any of the patients with Noonan's. I know I briefly spoke to a cardiology at my center who I think there might be some spatterings of people, but I don't know the reasoning behind them. So yeah, probably not the best person, sorry.
I think like I could maybe weigh in just from working with kind of trametinib and then knowing kind of more about the Noonan syndrome lens, having done my own personal research as a parent. But I think when you're using a new drug that's considered experimental and not approved, as you said, for a certain population, you want to try to use it in a severe situation. So for sure, for Noonan syndrome, that hypertrophic cardiomyopathy, I think there's no known treatment for that. So trying a MEK inhibitor is absolutely like the way to go. And then I think in some of these side effects where they're unable to manage them with kind of standard treatment and they're causing pain, they're life-threatening, or they're causing severe impact on quality of life, any of those kind of general scenarios, I think it would make sense to try a MEK inhibitor. There is a question in the chat. Do you need to be more careful with G-tube injury in case of start of a MEK treatment?
Maybe.
I think, do you mean like the skin, like granulation tissue, or maybe? We've given trametinib to lots of kids with G-tubes and we haven't seen any changes in like stoma care or granulation tissue or anything like that, actually. Right, Tara?
Yes, correct. Yeah, I think there was a previous question as well, as well as the youngest child that we'd started it on, and on a MEK inhibitor, and I think definitely under 6 months of recent. I know every country is different. Maybe just going a little bit back to the reason like starting MEK inhibitors for off-label here in Canada when we're using a medication that's not on the market. So liquid trametinib, especially for those younger kids, is not on the market. So we need to, our process in every country is different. We have to get Health Canada approval in order to be able to use that, and then so the physician has to apply to Health Canada in order to say this is the reason why we're using this. This is the research and the evidence, and then from there they coordinate with the drug company. If it's if it is on the market, so they can swallow, then I think everybody's country is a little bit different as far as getting access to the other drug company or other ways of paying for the medication. And then let me just see, I think I saw another.
And it looks like there is cases of MEK inhibitors being used in adult patients as well. So it's
that's where
someone
it's
responded that their
yeah.
their daughter's 26. So
Yeah.
Right. And that would probably be easier to access because
Yeah.
it is approved in adults.
Mhm.
There's a question, Tara, do you have any experience using MEK and mTOR inhibitors together?
Not myself, but I know some of my colleagues that I collaborate with in the States are starting to use that. From what I gather, I think the side effect profile is more significant from what I've heard, but I don't have direct experience myself.
I see a question about a child with Costello syndrome with HCM, and we do know there was a family that came and shared their experience about using MEK inhibitor. I don't know remember which one, to avoid a third heart surgery, and it seemed to be doing pretty well. And they were having the skin issue that was manageable with over-the-counter stuff. So definitely, it's been used for compassionate use for Costello children with HCM. Not very many, but definitely.
Tara, I have a question. Do you have any advice for parents who feel that their child may be in a situation where they need to access like a MEK inhibitor, and how to approach that with their physician or like medical team?
Yeah, I think finding a team that's maybe going to look out of the box for stuff, like presumably, since this is certainly not standard use, but having somebody that will explore the evidence with you, that you feel confident to be able to ask the question. I'm sure you guys are all good at plugging through the research yourself to be like, hey, look, have you thought about this? Or do you know somebody that has looked into this? I've heard, and not being intrusive about it, like trying to be collaborative together. I think so being working as a team to be like, hey, I know we've tried this. I'm wondering if this would be a benefit to my child. And just trying to, whether if you're able to pull together the research that you've done, and then if you have a primary care provider, whomever it is that takes care of your child, that is an out of the box thinker, or who would be happy to refer you to someone who maybe has a bit more experience, just so you can kind of explore if this is the right thing for them. But I think really being able to collaborate together with whoever that might be, and not and ask to and politely ask to see if it's to see somebody else if it's not if you're not kind of getting your questions answered. I think that goes, you guys know your child best and you guys want what's best for them. So I think really good, clear communication, collaboration, and then if things are still not going great, then trying to seek alternative people to speak to.
actually, do you know if you talked about collaborating with other specialties like dermatologists and having the dermatologists work in your groups? So is that just in the context of a clinical trial, or do you think if a doctor is gonna that can happen outside of the
Oh no, this
trial?
happens. So it's taken a while, and for our center to be able to do this, and we're a bigger center in Toronto in comparison to other centers, but because of all of the, and MEK inhibitors aren't the only one. There's other targeted medications that are happening that causes skin effects within the oncology world specifically. So we were having lots of trouble getting access to them because we were struggling of what to do. And then thankfully there was a couple that were really engaged in learning it more about it. And then from there we proposed kind of having shared clinic time. It's still only once a month, but at least there's a point of contact and there's somebody who's engaged and active and wants to be involved and wants to learn and is part of whether it be national or international dermatology groups as well too, are also looking at those side effects. So there's I'm going to forget, there's a pediatric dermatology consortium that specifically looks at kind of targetable side effect profile and management. And I know that they do lots of education together, and they sometimes post different modalities on there. I can send it afterwards because I'm blanking a little bit on what they're called, but I know that our group recently published kind of these YouTube videos to help manage MEK inhibitor rashes and education for patients and family that are basic but nice and like straightforward and easy to follow. So I can share that with you afterwards.
That would be great.
There is a question that are there improvements with hypertrophic cardiomyopathy with trametinib treatment? I think maybe I'll answer that because I know Tara is not a Noonan syndrome expert, but I think the answer is we don't know because there isn't actual like clinical evidence or studies that have been done yet to prove or use trametinib for Noonan syndrome. But there has certainly been lots of case scenarios, which is one patient trying trametinib and a doctor writing up a report on that one patient and saying, explaining how that went. And I think it's actually like consistently showing that it is improving hypertrophic cardiomyopathy, but certainly more research needs to be done to prove that it could be a standard therapy in Noonan syndrome patients with hypertrophic cardiomyopathy. Does that make sense, Beth? I don't know if I answered it all.
Yeah, no, I think I totally agree with that. Dr. Andelfinger and Dr. Gelb and some other international colleagues are definitely, if they haven't already published, they will soon be publishing information about, I think, a cohort, a little bit bigger cohort, still not a clinical trial, but I think they've treated maybe 17 or maybe up to 24 patients now that they're trying to basically write up a very, quantitative, rigorous study in hopes of getting the FDA to start or to approve the first sort of registration trial or phase 1 trial. So we're getting pretty close, but yeah, it's definitely not quite in the phase of doing clinical trials yet.
And remember, keep in mind, this really is for children who need it for compassionate use. The cases are like avoiding heart transplantation. So it's really pretty serious.
Yeah.
Right.
Then there's a question, do the cardiac side effects outweigh the potential cardiac benefit from hypertrophic cardiomyopathy? I don't know if Tara can necessarily speak to that either, but
I think it all comes, I think ultimately, and I'm also seeing it will be kind of like what the other alternatives is, like at what point your child is at, and the reason for going, and as Lisa just kind of said, that the reason for going on MEK inhibitors is to avoid a heart transplant, then kind of looking at pros and cons, and then discussing with your healthcare team, then perhaps that does, and then it's just close surveillance monitoring of those cardiac side effects. And I was trying to dig through just because we now know the right doses or the therapeutic doses for kids in varying ages, and whether or not this group of patients, I kind of think the early trials of trametinib on the Noonan's patients that I was reading briefly, they were giving smaller amounts just to see if they could still have the same effect because of the worry of cardiac stuff, but I haven't read the most recent bits as well too. Once again, something to kind of discuss if that makes sense for your child.
And certainly in the brain tumor population and the NF1 population, we haven't seen severe cardiac side effects. Would you say that's true, Tara?
No, it's true. And there was more severe in the adult world, but presumably that's because of the kind of the age and just all of the other predisposing factors that happens as adults with having, whether it be cardiovascular damage as you get older. So that's where all the cardiac monitoring came from. And obviously there's changes that happen, but there is very few to little that have caused symptomatic side effects for children who've been on clinical trials too, from a cardiac perspective.
And in the odd case where we saw something, stopping the drug usually improved it quite quickly as well, which I think is important, right, Tara? Is that right? I'm like,
yeah,
I used to do this 3 years ago. So little bag.
She was great.
There's a question. Oh, go ahead.
Go ahead. No. Yeah. How about using it for treatment of lymphatics and lungs? So again, like, I don't think Tara can speak to that, but if the condition was severe and life-threatening, it's certainly worth discussing with your doctor.
I believe there are 1 or 2 cases of usage for lymphatic issues that have been
Yeah.
reported. I think in Noonan syndrome, right? The 2
Yeah, I
Noonan.
briefly saw that when I did my little, but I think once again, just since your RASopathy group is just so niche and there's not as many treatment options, so having that discussion with your team to see if that makes sense.
Mhm.
Yeah, there have been a few published case studies of using trametinib for severe lymphatic anomalies, and they showed some improvement. Anybody else?
Tara, one last thing I just thought of is how quickly does trametinib work? Do you think you can answer that question? That's a hard question.
Good. That's a hard question. I guess, you know what, I probably should have added that to my list of a bit of unknowns. There's the half-life of trametinib is actually pretty long. It's 3 to 4 days of the half-life. But there's some, depending on the reason that you're starting it, we don't do MRIs every week, obviously, to monitor our kids, but some of the clinical side effects that we see, there's some group of kids that we would, for instance, for a plexiform, for a kid who was having pretty intractable pain, we saw a change within a couple weeks. However, with others, the reported results for the Pediatric Low-Grade Glioma Consortium was approximately 9 to 12 months before there was a kind of change in their MRI. And sometimes can be longer and sometimes can be shorter, but on average, it seems to be that 9 to 12 months. So across the board, obviously, for the reason why you're treating, it could be very variable, but this is more of a longer term therapy.
I guess another point to that is that if you are kind of in a situation, especially with hypertrophic cardiomyopathy, talking to your doctor early would be important to kind of get the ball rolling and see if this is an option for you.
Oh, thank you so much for sharing. A child with Costello syndrome, G12C, started taking trametinib for HCM and valvular obstruction at 2 months old.
And now she's 3.
Yeah. So do you mind sharing how that seems to be affecting the HCM? You can do it in the chat.
I'm not the one who wrote that, but I have talked with 2 of the parents of Costello syndrome children who've taken this for hypertrophic cardiomyopathy, and they both had very good results and just minimal skin rash. So that's why I'm asking, because my child is the one who's 9, who's at the point where we don't want to do a second heart surgery. In fact, the first surgeon said that there was a lot to lose and very little to gain with a second surgery. But yet we're at this position where we have to do, he has hip dysplasia, bilateral, and it's starting to get problematic. And so that's why we're looking into it, because we're in a spot where there's nothing else to try.
And certainly some people don't get severe skin rashes and it's very tolerable. Like unfortunately, you just don't know who, like if you're going to have a severe or mild rash.
And I think I'll just say, like, for patients who you guys have been managing your child's diseases in so many ways since they, whether it be they've been born or when you've discovered their diagnosis, and there's ways to, and like I said, I collaborate all the time with families. I'm like, they could be very mild, but we figure it out. We figure out ways of working together, be able to reduce the side effects. So it's all to say that yes, side effects will happen. But for the most part, most of the families, I see the question in the chat about kind of side effects of MEK inhibitor versus a chemo. And I think a lot of families enjoy the MEK inhibitor since it's an oral daily medication that their child takes. They can go on vacations, they can go to school regularly. There's a lot in comparison to kind of IV chemotherapy, which is a little more, not only can it affect their immune system and various other things, but needing to be at the hospital is a lot more significant. But it's all stuff that we eventually figure out. That is a change in the routine of skincare and being aware of all these different side effects, but that's something I'm sure you guys have all adapted your lives of having to be aware of all of these other new things that that are forever changing, right? So I would say that even though, yeah, the side effects are real and the pictures can look like a bit frightening, but we always eventually figure them out. But it's important of just having a team that you can collaborate to figure them out.
Absolutely. And I think, you know, a lot of the times we don't take kids off of trametinib for side effects. Like, we're fortunate in that sense that we are able to really manage these skin side effects and continue treatment. I think we're getting close to the time.
Yep. I'm wondering if there are any, have we heard from any cardiofacciocutaneous syndrome families that they've used it? So, I mean, RAF, MEK, and RAS in CFC. Not sure if they tend to have the same degree of cardiac problems. Do you know of any CFC patients who have taken it? Anybody?
Oh, I do know that they do. HCM is common among them, so that's a really good question.
Okay. Yeah, that's true. But BRAF. Okay. Well, this has been super informative, super interesting. I think it's something that, you know, parents need to be prepared for in considering taking these new drugs and new therapies that are going to come into the pipeline in the future. So it's definitely worth hearing your experience, and thanks for sharing all of that. If there's no further questions or comments, it looks like we've got some emails coming out in the chat. If you want to add any last thoughts, we will close. I want to thank again Andrea and Tara so much for coming on and moderating and sharing and just making us all a little bit better informed about these potential treatments.
Thanks for including me.
All right, we'll catch you again for the next webinar coming up in the next few months, so stay tuned. Bye, everybody.
Thank you.